بسم الله الرحمن الرحيم. طبعا النهارده في الليله مباركه من ايام رمضان بنلتقي طبعا على مأدبة العلم، وباسمكم جميعا بتوجه بخالص الشكر والتقدير والتحيه للاستاذ الدكتور وسام اسماعيل على ما تقدمه من مجهودات عظيمه جدا، يعني خلت النفرولوجيست يعرفوا اسرار الباثولوجي النفروباثولوجي بشكل جميل جدا. النهارده الحلقه رقم 11 وده بيوري مدى الاخلاص والحماس، ومش عارفين نشكر الدكتور وسام وانا بتفق مع اخونا الدكتور طارق طنطاوي قبل الميتنج كان بيقول كلام فعلا كلام اقل مما تستحقه الاستاذ الدكتور وسام. النهارده هنتكلم عن التوبولو انترستيشال ديزيز، واحنا يمكن في النفرولوجي ساعات بنهمله، وحتى كلاسيفيكيشن ساعات بتهمله، الا انه من البروجنوستيك كرايتيريا الخطيره جدا، ناهيك على انه هو one of the diseases that affect the kidney. فبتهيألي الدكتوره وسام النهارده هتمتعنا بحلقه على النفرايتس. اتفضلي دكتوره وسام.
شكرا دكتور حسين، ويعني it's always a pleasure to be with you. And يعني this is one of the most interesting topics for me. I think it's always يعني from my point of view it's a very entertaining lecture. زي ما حضرتك قلت Tubulointerstitial diseases are always down the list. ما حدش بيفكر فيها قوي. فيها حاجات كتير قوي مهمة و I like them because I think they are very challenging, much more than glomerular diseases. النهارده I'll try as much as possible to give you an overview لأن يعني Tubulointerstitial diseases are a lot، وحاولت على قد ما أقدر إن الoverview ده يبقى comprehensive. You will see quite common entities we see يعني we encounter within our patients, but you will also see quite rare entities. يعني I added them because they are interesting. Some of you might يعني see a single case during their lifetimes or might not, but they are still interesting entities and they are worth knowing. Okay, I'll start when we come to discuss tubulointerstitial diseases. I want you to know that tubular and interstitial diseases are considered actually as one entity. And so between the spectrum of an acute tubular injury to what we consider acute tubulointerstitial nephritis or chronic tubulointerstitial disease, more or less we are actually considering a spectrum of the same diseases. They are tubulointerstitial compartments are actually affected with a wide variety of renal and systemic diseases. They can be primary or secondary. And the most important point I would like to start with that this is the compartment which correlates with the renal function. So the renal function actually directly correlates with the tubulointerstitial compartment rather than any other compartment of the kidney. From the point of view of the anatomy or histology, the tubulointerstitial compartment of the kidney makes around 80% of the total kidney volume. The tubular segments comprise the major part of the nephron, actually, and are structurally and functionally heterogeneous. You know this. We have so many different types of tubules. And the interstitium is the extravascular intertubular space, and this space is formed of cells and extracellular matrix. This is an example of the variety or the heterogeneity of the tubules of the tubular system. We have, proximal tubules, distal proximal convoluted tubules, distal convoluted tubules, the collecting system, the connecting tubules and collecting ducts. You know, of course, these things, loop of Henle. And from the point of view of the biopsy, we mainly deal with the distal and proximal convoluted tubules and sometimes the collecting ducts. Since these are the major components of the renal biopsy, so they are actually the major ones with the histological findings we judge the biopsy on. This is a normal proximal tubule, and this is what we call proximal tubule. You have these tubules are lined by high columnar epithelium with abundant eosinophilic cytoplasm. This cytoplasm is usually granular because it has high mitochondrial content, and it has a brush border. This very thin red color is a brush border, and you can see it much more apparent in the PES section. See, this is what we call the brush border, and these are the tubular basement membranes. On the other hand, distal tubules are lined by low cuboidal epithelium, and the nuclei tends to be a bit more rounded, and the epithelium is smaller, as you can see, in size, and they have no brush border. And as you can see in the PES, you can appreciate that there is no brush border here. So this is the proximal tubules, and these are the distal tubules. The interstitium is composed of a loosely organized matrix containing the interstitial cells. What are the interstitial cells? They are the fibroblasts, they are macrophages, they are dendritic cells. And this extracellular matrix is composed of collagen fibers 1, 3, and 6, proteoglycans, and glycoproteins, mainly fibronectin and laminin. The relative interstitial volume varies in different compartments of the kidney. So cortex is from 7 to 9% only, and medulla is from 30 to 40%. This is why when we come to judge on the interstitial volume, we judge on it in the cortex, because normally you have expanded interstitial volume in the medulla. And this is why we usually comment on the interstitium that it's within normal limits, that it's not normal. So we have a percentage of from 7 to 9% of interstitial expansion, mainly fibrosis, which we consider normal. This percentage comprise the tubular basement membranes, as you can see here, because they are also collagen, and also the perivascular areas, because the perivascular areas, you allow for interstitial expansion in them. So there is a minimal volume of interstitial fibrosis, which we accept within a normal kidney, which is from 7 to 9%. So above 10%, we start to consider that this is pathological. When we come to examine the tubulointerstitial compartment, it's actually much more exhausting than you think. Glomeruli are much easier, because in examination, when examining the tubules, we need to look at the tubular cells in relation to their size, shape, cytoplasm, brush border, and their nuclei. Then you look at tubular lumina. Again, the size of the lumen of the tubules and whether the tubular lumina has any contents. Do you have cells? Do you have casts? Do you have crystals? And whether you have inflammation or not. If this inflammation, we call tubulitis. And within tubulitis, which type of cell is causing this tubulitis? We also look at the integrity of the tubule itself, meaning the basement membrane of the tubule. Is it within its normal contour and normal structure? Is this tubule collapsed? Is it atrophic? Is it dilated? Is it hypertrophic? And tubular basement membranes, are they thickened? Do they have any deposits? Are they destructed? As I'm going to show you in the examples to follow. Then in the interstitial space, you evaluate interstitial space by the presence of edema, inflammatory cells, fibrosis, if you have accumulation of other cells or deposits, if you have accumulation of any material or deposits in the interstitium. And then we also look at the peritubular capillaries and whether these peritubular capillaries have inflammatory cells or they are congested. Of course, peritubular capillaries have much more importance in transplant biopsies, but they are also important in native kidneys, as I'm going to show you. So from the point of tubulointerstitial diseases, if you want to classify them, but I have to tell you this is a fruitless classification, but this is the only classification we have. We classify them into primary and secondary tubulointerstitial diseases. Primary includes everything we know in medicine: genetic, infection, immunological, drug-induced, toxic, special types of chronic interstitial nephritis, as are staphylococcus acid nephropathy, metabolic, ischemic, radiation nephropathy, and idiopathic, if we don't know what's the problem. Then tubulointerstitial compartment can be affected secondary to glomerular diseases, to vascular diseases, to obstructive disease, if you have cystic disease, and of course, reflux nephropathy. Mostly the diagnosis of the etiology, whether this is a primary or a secondary cause on biopsy basis, is not that easy as much as you think, or as much as we would like. And as we all know, the tubulointerstitial diseases presents with acute kidney injury. Whether this acute kidney injury is superimposed on already a chronic insult, or this is the first presentation of the patient, this is mainly how tubulointerstitial diseases will present. When we come to discuss AKI, this is, you know this better than me, and then you know that up to 60 to 70% are pre-renal, up to 40% are intrinsic, and only 5 to 10% are post-renal. And for the sake of our discussion, we're mainly interested in the intrinsic part. And the intrinsic part, as you can see, tubular cell injury actually composes around 90% of the causes of acute kidney injury, leaving only 10% to acute interstitial nephritis and less than 5% to acute glomerulonephritis. So acute tubular injury or tubular cell injury is the major cause of acute kidney injury. Ischemic in around 50% of cases and toxic in 35 to 50% of cases. So we will start with ATN, or acute tubular necrosis. Now, acute tubular necrosis is a clinical pathological term. Again, this is one of the misnomers in medicine, a huge misnomer, I have to say, and one of the old wrong terminology, which is proving to be very difficult to change. Acute tubular necrosis mainly means acute deterioration of renal function due to epithelial injury, and means that this is a patient which will present with reversible acute kidney injury. This is what you all know. So a patient with ATN is a patient with reversible acute kidney injury, and in pathology we have tubular injury. So why are we calling it acute tubular necrosis? This term has changed into acute tubular injury, ATI, not ATN. It's the same thing, but this is now. ATI is a synonym meaning that necrosis involves the cells and it's not geographical, and that it's focal and limited to a small percentage of tubules. وفي مشكلة في الصوت؟
لحظة بس يا دكتور وسام بعد إذنك، لحظة واحدة. اتفضل يا دكتور وسام.
So, acute tubular injury is a more correct term because this means that the necrosis is insignificant and is on the cellular level. We don't have segments, whole segment of the cortex which is necrotic, and that this necrosis is focal and limited to a small percentage of tubules. This is why this condition is reversible. This is what we call ATI or tubular necrosis. You have some tubules which are necrotic, but the rest only have injury, and this is a very not a healthy, I mean non-necrotic tubule, a viable tubule, as you can see here. This is pure ATI. Again, we call this ATN, when all we have here is just injury. There is no necrosis at all. Why is this important? Because acute tubular injury is a sublethal injury. These are your patients which are reversible. And why is it more important? Because we do have patients with acute tubular necrosis, and this one is an irreversible injury. Let me take you back to the pathology in third year medical school, when we were teaching in pathology that we have irreversible cell injury, which is cell death, which is necrosis. And we have reversible cell injury, which is hydropic degeneration or whatever type of it is. So what you call ATN is supposed to be a reversible injury, and we cannot call it necrosis. And we do know that we do have patients which present with necrosis. Necrosis heals by fibrosis and scarring of the kidney. It cannot be a reversible injury. This is why this term is not used anymore, and the proper term is acute tubular injury. So ATI replaces the term ATN, so we can leave the term tubular necrosis for these cases with actual necrosis, where then you know that your patient is going to have scarring and the renal function is not going to return to normal, depending on the percentage of necrosis, of course. As I said, the majority of cases of ATI is ischemic. And as you can see here, again, a tubular cell injury is either reversible or irreversible. If it's reversible, then this patient is going to recover. It's irreversible. We have necrosis and apoptosis. Both will lead to reduced glomerular filtration rate and oliguria. The difference is in the prognosis and whether our patient is going to recover completely or is left with a residual chronic insult. The pathogenesis, what happens in the reversible injury, basically includes that you get bleeding of the microvilli, loss of the actin cytoskeletal structure, you have loss of cell and cell contents, you have redistribution of the sodium potassium ATPase, and so on. All of these changes actually are reversible because eventually all of this is regenerated, and there is the brush border of the tubules is regenerated, and it leads to recovery. If we have destruction of the tubular basement membranes, then this is when you have necrosis and you have irreversible injury. Without the basement membrane of the tubules are not going to be able to regenerate again. Theoretically speaking, and I have to say theoretically speaking because I will surprise you by telling you that what we know about the pathology / histology of acute tubular injury is actually very limited. Why is it very limited? Because all what we know is from experimental evidence. Again, why? Because you know better than me that very few patients with AKI are actually biopsied. And usually when they are biopsied, it's a late biopsy. So what happens actually in acute kidney injury, what happens within the acute tubular injury and the full spectrum of this pathology, we don't really know. What we know is only experimental. So theoretically, in the ischemic type of injury, you get more costs than necrosis, and the necrosis affects more the proximal convoluted tubules more than the distal convoluted tubules, which are usually full of costs. And I'm going to say what type of costs do we have. On the other hand, in the toxic type, the necrosis is more evident than the cost. So the more we have a more prominent tubular injury, the more probable the cause is that it's toxic. In toxic tubular injury, the extent of injury we see will depend on so many things. Depends on the type of agent, depends on the dose, and depends on the time of the biopsy. When did we take the biopsy? Secondary injury can also occur, and this secondary injury can include some interstitial inflammation, and hence the picture can change from a pure tubular injury into an interstitial nephritis. And comes the dilemma. Is this the tubulointerstitial nephritis, which actually is resolving and the residual element is the tubular injury, or is this a tubular injury, a toxic tubular injury, with eventually, because the biopsy comes late, and then we have an interstitial infiltrate? It's not easy at all to judge. As I said, our experience is limited. Biopsies are very few. When we have biopsies, usually patients are either treated and they are responsive to treatment, and the biopsies are usually late. It depends, of course, on the cause and on the dose. If the patient is exposed to a high toxic dose, then you will probably see a much more prominent injury rather than a mild or a chronic progressive injury. This is one of the first examples of mild tubular injury. The other problem we have with tubular injury is that the morphology does not correlate with the renal function. Please always know this. This type of pathology or pathogenesis of these diseases is very, very patchy. So what you sample in the biopsy is not always reflective in the kidney. So the fact is this a mild injury, a moderate injury, or a marked injury because you want to know, because you want to correlate it with the renal function of the patient? Unfortunately, it doesn't correlate with the renal function of the patient. So you can have a patient with a creatinine of 9, and this is his biopsy. Mildly injured tubules. This is how early tubular injury starts. You get lost individual cell degeneration, loss of the sum of the nuclei, no brush border or actually just interrupted brush border, and very early hydropic degeneration, mainly noted in the proximal tubules. And the distal tubules are more or less normal. This is a distal tubule, this is a proximal tubule. So this is a very early sign of injury. Other than sometimes this is what you get. This is what we call vacuolation of the tubules. And vacuolation can either be isometric, means that they are equal, or they can be variable in size, as you can see here, non-isometric vacuolation. So we get extensive vacuolation of the tubular epithelium, as you can see here, and it's not equal. This is a trichrome stain. Do you see the vacuoles inside? This is what we call hydropic degeneration, again, ATI. Look here again. So all of this white inside the tubular epithelial cells is vacuolation. Again, this is isometric vacuolation. They are more or less all equal, and the injury, the extent of injury is more or less the same. This is a drug-induced injury. This was a case of IVIG. This was a patient who had this tubular injury. This is one of the hyperosmolar tubular injury you can see sometimes with intravenous infusions. Sometimes you get complete flattening of the epithelium, as you can see here, and dilatation of the tubules. So these are way proximal tubules, and you can compare with the thickness of the lining that you can see here, complete flattening of these tubules in H&E and in trichrome, and slightly congested peritubular capillaries. When tubules are regenerating, as you can see here, you sometimes you get mitosis. This is very this was a nice incidental finding in one of the biopsy, and you can see here this is mitosis. So these are actually regenerating tubular cells. Tubular cells start to pleb, and they start to have bizarre nuclei, and all of these are evidence of regeneration. These tubules are regenerating. With a more severe injury, you start to have necrosis. And as you can see with this biopsy, this patient had mainly more necrosis in the cells with loss of the nuclei. So the salient feature was necrosis. Again, intact membranes, minimal infiltrate, and this patient can also recover. Part of the spectrum of acute tubular injury is the presence of costs. The costs in acute tubular injury vary. They can be all costs formed of necrotic debris, as you can see here, and as you can see in this one, or they can be what we call pigment costs. Now, I know that most of you think of pigment costs in relation to rhabdomyolysis, to hemoglobinuria, but we can have innocent pigment costs like these ones, or not innocent. We accept a certain amount of pigment costs within the context of acute tubular injury. This is classically what a pigment cost looks like. You have this circular things here. Look at this one. This was a remarkable tubular injury. You can look here at the extent of vacuolation in the tubule and look at the amount of costs. There are a lot of necrotic cells, pigment costs, some inflammatory cells. And again, this is only acute tubular injury. This patient did not have anything specific. But of course, when we see pigment costs, they have to get into the differential diagnosis of light chain cost nephropathy, because light chains can mimic pigment costs, and mainly rhabdomyolysis. Again, rhabdomyolysis can be mild, and you can have just pigment costs in the biopsy.
We have a very nice case, Dr. Wesam, of pigmented cast in our series. This was a biopsy done intraoperative from the kidney donor in the era that we do angiography. So we stopped the policy of invasive angiography because the contrast even may lead to cast mimicking pigmented cast.
Yes. So these casts, which are mimicking pigmented casts, or we consider, as pathologists, we consider them pigment casts, and we consider them within the spectrum of an acute tubular injury if they are not within a certain percentage, of course, within the clinical context of the patient, and if they don't prove to be anything else. Out of the spectrum of pigmented casts or pigmented material within the kidney, bile casts. Now, these are extremely rare. I don't want you to consider them that this is a common finding, and bile casts are usually post-mortem findings. But I did have a couple of cases with patients who developed acute kidney injury, and they both had obstructive jaundice. So this condition occurs, and as you can see, this is bile. And we know bile because it gives this nice goldish brown color. Still, the patient had other proteinaceous causes as a part of tubular injury. Look here, and this is classic. This is actually bile. The patient had obstructive jaundice with very high levels of bilirubin. Again, rare entity, but these were interesting cases. And as I said, this happens. We don't usually consider them within the differential diagnosis of pigment casts. But if you see them, and if the patient clinically fits, then this is a bile cast nephropathy.
Is it necessary to have Hall's stains for the bile cast or colemic nephropathy?
No, usually a trained pathologist can recognize bile.
Okay.
This is just part of our training. We all train on recognizing bile. This is an important part in the training of general pathology. So we get to know it from the liver biopsy. What you can mix with bile, however, is hemosiderin. But hemosiderin, again, trained pathologists will know the difference. Hemosiderin, as you can see, have a darker color. And this was also an interesting biopsy, and rarely you get this amount of hemosiderin. The main difference is that you don't get hemosiderin as casts. Hemosiderin is usually present inside the tubular epithelium, as you can see in this biopsy, from patients with hemolysis-induced acute kidney injury. So hemosiderin here is actually evidence of extensive hemolysis, and sometimes we get it within the interstitium or within the tubular cells. An uncommon finding, not rare, but don't confuse it with bile. As I said, bile forms actual casts, while hemosiderin, as you can see, gets inside the tubular epithelium. Another spectrum of acute tubular injury is calcification. So not every calcification you see in the kidney is nephrocalcinosis. A good percentage of drug-induced injury, again, intoxic tubular injury, causes calcification. So especially, of course, calcineurin inhibitors. So as you can see here in this patient, this is calcification in the tubules, but any other form of acute tubular injury, you can still find calcification within the tubules. And calcification doesn't resolve. I have patients with biopsies 2 or 3 years following a history of calcineurin inhibitors, they still have the calcification in the tubules. So, but again, it will raise the differential diagnosis of nephrocalcinosis / acute phosphate nephropathy. This was an extensive case, and this patient had almost a calcified kidney, as you can see here, the extent of calcium. This is with von Koster-Stein, and you can see this. This patient had acute phosphate nephropathy, but nephrocalcinosis can be very mild and subtle because it starts within the tubular cytoplasm, and it's not always easy to detect. So the early cases can be actually missed. Like this one, you can see this patient, most of his kidney had unexplained rise in his serum creatinine, and most of his kidney was actually normal, but look at this tubule where you can see the calcium inside the tubular cells. This was also nephrocalcinosis. As I said, the spectrum between tubular injury and tubulointerstitial nephritis, or the sharp line between a tubular injury and tubulointerstitial nephritis, is not always that clear, or you cannot actually always sharply delineate between them. However, when we come to discuss tubulointerstitial nephritis, as you all know, can be acute or chronic or both. So can we have an acute exacerbation on top of a chronic interstitial nephritis? Yes, of course. The type of infiltrate may provide a clue to the underlying etiology, but not always. So if you have a neutrophil dominant infiltrate, then yes, probably this is bacterial. Eosinophils are not that much conclusive as you think, and lymphoplasmacytic infiltrates or a plasma cell-rich infiltrate also can give you a clue to the underlying etiology. But at the end of the day, you might just end up with just a tubulointerstitial nephritis. Not all cases of tubulointerstitial nephritis would have tubulitis, which is inflammation in the tubules. The extent of tubulitis would vary, and hence, as I said, the eternal problem of, was this an acute tubular injury with eventual inflammatory cells infiltrating the kidney in the process of repair, or is this an acute interstitial nephritis which resolved? Is it an ATI or is it an AIN? It's not always that easy to differentiate between them. So you need clinically also to consider this and know that even if patient is a pure acute tubular injury, some of the infiltrate is allowed within the kidney. So not every infiltrate you see in the kidney should be diagnosed as tubulointerstitial nephritis, and not all these patients should receive corticosteroids. So again, this is an evaluation by the percentage of the infiltrate and the dominant arm in the injury. is the dominant arm tubular or is it interstitial? And even if it was an acute interstitial nephritis and within the biopsy, the dominant arm is tubular, that means that your patient is actually resolving. So you need to consider this and correlate the biopsy with the timing of the biopsy. Here, the timing is the essential arm. As you all know, acute interstitial nephritis presents, this is mainly for the pathologists here, it's not for nephrologists, of course, but interstitial nephritis will present with acute renal impairment in 100% of cases, microhematuria and up to 70%, leukocyturia and non-nephrotic proteinuria, but you have a percentage of patients which will present with nephrotic range proteinuria, and this is the ones with the protein costs like light chain, like myoglobin, because these are actually a lot of protein costs. So these patients will present with nephrotic range proteinuria without glomerular disease, and some of them can present with complete nephrotic syndrome. And not all of them have eosinophilia. Not all would present with a full allergic syndrome. If we come to consider the etiology of biopsy-proven acute interstitial nephritis, this comes from an article, a Spanish article in 2010, and you have to know that etiology of acute interstitial nephritis differs between countries because it will differ with the culture and with the epidemiology of the countries. So according to them, up to 50% of cases of their acute interstitial nephritis were drug-induced. And I can say that this is also applicable to us. They have only 5 to 10% of the causes infections. For us here, I will increase this percentage. And if you look at the extent of the infections which can cause acute interstitial nephritis, you can see that we have bacteria, we have viruses, we have protozoal infections. So the list is long. So not very specific infections only which can cause AIN. And some of them, of course, are idiopathic. And we have a percentage which is associated with systemic diseases. Acute interstitial
كده عشان ايه؟ صلي ما شاء الله.
دكتور حسين في صوت في As I said, in acute tubular injury, the morphology doesn't correlate with the renal function, while in interstitial nephritis, no, it will correlate with the renal function because the reduced glomerular filtration rate you see depends on the severity of inflammation. Interstitial edema will cause elevated intratubular pressure, intratubular obstruction with the intraluminal cells. As you know, tubular back leak and tubular glomerular feedback, as you all know about this. Infectious nephritis can be either direct or a direct invasion or by remote infections like streptococci, like parasites, like leishmania, and viruses. Pathogenesis is usually an immunological hypersensitivity reaction. Let's talk about acute pyelonephritis or acute bacterial nephritis. I have alluded to it before when we discussed infections, and we said that the commonest organisms are E. coli in pyelonephritis. This is usually noted in children or in young adolescents, or in adults. It's not a common finding except in transplant patients. You get all types of organisms like Proteus, Klebsiella, Pseudomonas, and so on. And as you know, predisposing factors are obstruction, diabetes, pregnancy, and of course, transplantation and immunosuppression. This is how acute pyelonephritis looks like in the biopsy. You get an extensive neutrophilic infiltrate and mainly neutrophilic tubularis. I'm not going to get into pathogenesis of UTI, you know it better than me. I'll just show you this is what we mean by neutrophilic tubularis. So the cells which are attacking the tubules are actually neutrophils, not lymphocytes. And you get a lot of costs, and these costs contain neutrophils. Neutrophils are a whole mark. دكتور حسين في
هلا
جاي مش عارفه منين.
طب
هات
استاذنك
السماعه دي لو سمحتي تعالي.
استاذنك
السماعة
لحظه،
بتاعتك.
استاذنك
اتفضل.
لحظه. انا مش عارف الناس اللي بتخش. اتفضل يا دكتور وسام.
Okay. As I said, neutrophils are a hallmark of pyelonephritis. So you don't get to diagnose pyelonephritis without neutrophils. You can see here is this patient extensive neutrophilic costs and neutrophilic tubulitis. It can upgrade up to abscesses, microabscesses we call them, with destruction. You can see here neutrophils again, neutrophilic tubulitis. Very nice. The important point to know is that when you get a pyelonephritis, especially not within the classic context of what you expect pyelonephritis, especially in transplant patients, you need to consider as well fungal infections. They are not always bacterial. Fungus as Candida, aspergillosis, and mucormycosis will give you the same picture. It will give a suppurative tubulointerstitial nephritis or a pyelonephritis. The most important complication of acute pyelonephritis is what we call chronic pyelonephritis. Now, this is one of the major wastebasket diagnoses of the chronic pyelonephritis. Now, I don't know about this, but chronic pyelonephritis falls into the differential diagnosis of tubulointerstitial nephritis, chronic tubulointerstitial nephritis associated with glomerular diseases like FSGS, or with hypertensive renal disease. Now, very, very important to know that if you get this picture of chronic interstitial nephritis and have a glomerular disease, you should not consider a separate diagnosis and don't add a separate diagnostic line called chronic tubulointerstitial nephritis, because this is only a part of the disease, of the glomerular disease, of the hypertensive renal disease, of the vascular disease. So don't use chronic interstitial nephritis except if this is the only single finding in the biopsy. But you get a lot of reports with focal segmental glomerulosclerosis and chronic interstitial nephritis. No, this is not applicable. It's not chronic interstitial nephritis. And chronic pyelonephritis is only used when I see
دكتور وسام.
طبعا في variants of chronic pyelonephritis زي xanthogranulomatoous pyelonephritis, malakoplakia, megalocytic interstitial nephritis, and their main differential diagnosis is renal cell carcinoma. Just to know. We've discussed leptospirosis before, and leptospirosis are basically, leptospira are nephrophilic, and their primary target are the proximal convoluted tubules, and they are regarded as the hallmark of renal injury. And as I said, it causes remarkable tubular injury and acute interstitial nephritis, and early on they are neutrophils. And within pyelonephritis, you start to have the concept of infections in general or bacterial infections. You start to see the neutrophils early on in peritubular capillaries before they even start to infiltrate the tubulointerstitium. And we're going to discuss this again because it's an important point in transplants. Other infections are CMV, and again, I'm going to discuss this in transplant, but you can see the viral inclusions within the tubular epithelium, and of course, Polyoma Virus Nephropathy, which is limited to graft biopsies. However, viral infections causes usually this pictures. You get bizarre nuclei, you get a tubular injury and bizarre enlarged nuclei. And the differential diagnosis of this picture is mainly, is this an overt regeneration of the tubules? Are we in what we call atypia of repair, regeneration atypia? Or are these viral inclusions? However, if we see this in a native biopsy with in a young adult around 35 or 40 years old with absolutely no history of viral infection and no reason for AKI, then we might consider quite a rare entity of tubulointerstitial diseases, which is known as cardiomegalic interstitial nephritis. Now, cardiomegalic interstitial nephritis or cardiomegalic tubulointerstitial nephritis, mainly you get what we call cardiomegalic changes in the tubular epithelium. This is a disease which was first reported in 1979 by Mihach from Basel in Switzerland. And up to now, only around 20 cases were reported in the literature. We have a case, actually a whole family, and it is from Mansoura. And these cases and these patients have marked cardiomegaly in the tubular epithelium. Cardiomegaly means markedly enlarged nuclei. You get marked enlargement of the nuclei up to 5 to 6-fold. They are hyperchromatic and you get irregular distribution. They have irregular outlines, and the most important thing is that they have no inclusions. This is a normal nucleus, and look at this one. And look at this one, and compare it to the normal nucleus, and then you can see the difference in the size. This is what we call cardiomegalic interstitial nephritis. If we want to know if this is a reparative injury or not, we do Ki-67. This is a marker for proliferation. It's an available marker and all pathologists know them, and these patients are Ki-67 negative. So this is a helpful diagnostic clue. Again, this is cardiomegalic, TIN. Here, as you can see, this is a rare entity, as I said, but it's an interesting disease, and it has been mapped recently to FAN1 mutations. It's not, these patients do not have anemia, they do not have Fanconi anemia, but they share the mutations of the same gene. And these these giant nuclei are also noted in smooth muscle cells, in Schwann cells, in the lung, in the liver, in the brain. So this is a form of a systemic disease. And they can also, this is a hereditary disease. It runs in families and mostly undiagnosed, and sometimes it's first diagnosed upon transplant, like in our case or the family we have. This is a 19-year-old female who presented with unexplained acute renal failure. Her serum creatinine was 9. She had around 2 grams proteinuria and hematuria, no history of hypertension or diabetes. Her immune profile was normal, virology was negative. She only had a history of NSAID abuse. 19-year-old female with NSAID abuse, yes, very, very common in females in childbearing period. They have, I can challenge you that if you looked at the bags of all females in the childbearing period, you will definitely find non-steroidal anti-inflammatory drugs. So this is a very common form of abuse. Tubulointerstitial nephritis. She did not have acute tubular interstitial nephritis, the regular one, but actually, as you can see, she had these large granulomas. And these granulomas were actually infiltrated with some eosinophils. And the adjacent tubules showed also eosinophilic tubularis. So acute interstitial nephritis, which is mainly caused by drugs, is a T-cell mediated reaction and can be granulomatous. And it's, I don't want only to stress that it can be granulomatous in 30% of cases, but I want to stress that the first differential diagnosis of granulomatous interstitial nephritis is not TB and it's not sarcoidosis, it's drugs. So when you get a patient with granulomatous interstitial nephritis, consider drugs first because this is actually the most common cause. The other two causes compared to drugs are much uncommon. The outcome, of course, depends on the extent of injury, and those with granulomas have irreversible injury, unfortunately, because this is considered a form of chronic injury. So eosinophils. When we come to discuss non-infectious tubulointerstitial, which we consider acute allergic TIN, which is a diagnosis mainly made by pathologists on the basis of the presence of eosinophils within the interstitial infiltrate. Let me tell you that eosinophils are non-specific cells. And although, yes, they can be considered a form of an allergic reaction, but we see eosinophils in an interstitial infiltrate in anything. So they are not diagnostic, and they are not a hallmark of a drug-induced tubulointerstitial nephritis. Induced tubulointerstitial nephritis can simply be without eosinophils. And an interstitial nephritis with eosinophils does not equal drug-induced. For example, you see much more interstitial nephritis with eosinophils in vascular diseases, in vasculitis, in patients with vascular rejection, and so on. So eosinophils are more related to vascular etiology rather than you would consider them allergic. And as we referred or we alluded to in diabetes, that you get all of this non-specific interstitial nephritis with eosinophils in diabetic patients, which is not related to drug-induced. So please be aware of the over-diagnosis of interstitial nephritis on the basis of the presence of eosinophilic infiltrate. Of course, you get some cases with dominant eosinophilic infiltrate, which you cannot ignore it. But if you have few eosinophils in the interstitial infiltrate, that does not have to be a drug-induced etiology. And if you don't have eosinophils, it does not exclude drug-induced. So they're simply non-specific cells. All my cases tonight are just demonstration cases, and the target or the aim of these cases, I will tell you at the end of the lecture. This is a 33-year-old female who presented with serum creatinine 8 from a baseline of 1.2. This patient had proteinuria 1 gram, no history of hypertension or diabetes. The only thing which was significant, and her immunology was negative, her virology is negative, and the only thing significant in her medical history was a history of cholecystectomy 2 months prior to presentation. And they said no drug abuse. This was difficult to believe because she had already cholecystitis. So this patient definitely had some form of painkillers. However, the cholecystectomy is 2 months prior to presentation. So we had to consider something else. Again, what you see here is a granulomatous tubulointerstitial nephritis. Extensive granulomas, what we call non-discrete granulomas, and with occasional joint cells. I'll show you. This is a granuloma, another granuloma, 1, 2, 3, 4, 5. And on a higher power, you can see the joint cells, and these joint cells are what pathologists call Langerhans joint cells with this peripheral joint cells nuclei lining again. So we have joint non-caseating or non-necrotizing joint cell granulomas, epithelioid granulomas in the tubulointerstitium. And you can look at these joint cells and they seem to be swallowing something here again. This patient had sarcoidosis. Now, sarcoidosis can cause acute or chronic renal failure. Within the spectrum of sarcoidosis affection in the kidney, you have normal glomeruli, non-caseating granuloma in the interstitium, interstitial inflammation, and tubular injury. Again, you see the granulomas are dominantly have giant cells. With more chronic disease, you're going to get interstitial fibrosis. The most important point is that sarcoidosis is a diagnosis of exclusion. Meaning, always remember that in sarcoid, you don't get isolated renal affection. مفيش حاجة اسمها عيان sarcoidosis هيجي برينال بس. This doesn't exist. If this is sarcoidosis, then this patient has other organ involvement, lymphadenopathy, hepatic, pulmonary, whatever it is. But there is no isolated renal involvement in sarcoid. If this is all what the patient has, then this is not sarcoidosis. And you need to rule out نعم.
ده نفس الكلام اللي احنا عشنا في رابطه الكلى من اسبوعين. كانت حاله من الدكتور محمد ممدوح مدرس مساعد معانا، كان جاي بيعرضها من ايطاليا، وكانوا ماشيين الدياجنوزس ساركويدوزس. انا قلت له ما دام ما فيش اذر دان الانترستيشن نفراس وجرانيلوماس في الكدني، ده مش هقدر اوافق على دياجنوزس اوف ساركويدوزس. فانا مبسوط ان حضرتك بتاكدي نفس الكلام النهارده.
very interesting الحقيقه، لان الطلاينه بالذات عندهم تندنسي لقصه الساركويدوزس دول، يعني عاملين كان في ريسنت ريبورت مطلعين كميه حالات related to ساركويد، مش عارفه عندهم some form of يعني بايس شويه بالساركويدوزس، بس yes this is a scientific fact. When we have granulomatous interstitial nephritis, as I said, we exclude what is common, and what is common is drug induced, and then we consider if the patient has other forms. This patient turned to have lymphadenopathy, and she had also some pulmonary affection, which was mild, and nobody actually considered it. So yes, because when nephrologists get a diagnosis of granulomatous interstitial nephritis, they only think tuberculosis and sarcoid, and if the patient is negative for TB, which we're going also to discuss, then they consider this sarcoidosis, and this is not fair. This is not how it goes. TB. After decline for almost 3 decades, TB is increasing, and you have to consider it. Genitourinary tuberculosis accounts for 30% of extrapulmonary TB. So this is a common form of affection, and it is common in our country. However, what's not common is to see granulomatous interstitial nephritis in tuberculosis. We did have a case also of a female patient with 32 years old, and I considered that it could be TB, and the patient did turn to be tuberculosis. But the common form of TB affection would be, as you can see, you get extensive damage of the kidney, joint cells, again Langerhans joint cells, and you get to see the caseation.
يعني الكازيشن بيبقى واضح، ما بيحتاجش.
لا مش شرط بيبقى واضح.
عشان كده امتى
بيبقى واضح في المظله، and we see them more in nephrectomies. بيبقى اوريدي العيان متشخص.
طيب دلوقتي هل بتعملوا مايكروبيولوجيكال ايفالويشن للسبيسمن ولا الكلام ده؟
احنا باثولوجي ما بنعملش مايكروبيولوجيكال ايفالويشن، وانا ما بعملش زيل نيلسون، لكن اكيد في other pathology labs بتعمل زيل نيلسون ستين، بس زيل نيلسون ستين مش سهله، مش always reproducible، ومش expected in a granulomatous tuberculous interstitial nephritis. انا هشوفها في الكورتكس ان انا اشوف بس اللاي، مش ده يعني، دي مش حاجه reproducible. يعني التي بي على فكره خادع قوي في الانترستيشن نفرايتس.
لا يعني انا ممكن اعمل في التيشو بي سي ار للتي بي، هل ده
هو ده
وعملناها عندنا هنا في حاله وطلعت نيجاتيف، وعلشان يبقى شور من الدياجنوزس وادينا ستيرويد، والعيان يعني وصلت لبيز لاين كرياتين معقول جدا بعد ما كان مبعوثه للزرع لتحضير الكرياتين 5 وطلع جرانيولوماتوس انترستيشال نفرايتس. واحنا اتعلمنا من الحاله دي وبعد القراءات ان زي ما حضرتك قلت كده الموست كومن كوز للجرانيولوماتوس انترستيشال نفرايتس هي دراج ابيوز.
وهو دي the important message. Tuberculosis you can diagnose. Sarcoid is a diagnosis of exclusion, and you need to have other systemic manifestations. And then what is left is drug-induced or idiopathic granulomatous interstitial nephritis if we don't know what is the cause. فيعني we need to think out of the box ونرتب الأولويات في differential diagnosis of a granulomatous TIM. This is a 27-year-old male who presented with nephrotic syndrome, hematuria, granular COS in urine, and a serum creat of 4.6. His ENA and ANCA negative, immunology profile normal, virology negative, نفس scenario, and this is the typical clinical scenario of all patients with TID. What's atypical in this patient is that he had nephrotic syndrome. He did not only have acute renal impairment and hematuria. Again, granulomatous interstitial nephritis, and I've shown you this case before, and you can see extensive eosinophilic granulomas with these bodies inside, and you can see a very nice meracidium of schistosomiasis, and again schistosomiasis as well as calcified ova. So this was schistosomiasis presenting as granulomatous TIN. This is not a common finding in this era of schistosomiasis. Of course, in the era before, all senior physicians have seen schistosomiasis infiltrating every single tissue we know in our body, but this have disappeared. But as you can see, this is not the single case we have. I have other cases of granulomatous TIN with actually ova in the tubulointerstitium. And don't forget that schistosomiasis is actually still the second most devastating parasitic disease following malaria. You seem to ignore it, you seem to forget it, and as we've discussed before, you also seem to forget that we still do have patients. It's not as it was before, but we still do have patients with schistosomiasis. This patient had membranous nephropathy as well, which was primary and phospholipase associated, and it was just a coincidental finding, and this was the cause of his nephrotic syndrome. Crystals. Let's move to another aspect of what we see in tubulointerstitial diseases. Now, this is an important aspect. Now, crystals. How do we think or approach crystals in a biopsy? Now, crystals can also be encountered within the spectrum of an acute tubular injury, like this patient. So this patient had an acute tubular injury with these proteinaceous costs within the tubules, with mild interstitial inflammation and edema, and then this crystals here. Do you consider this oxalate nephropathy? No, be careful, because we have acute tubular injury with oxalosis, with crystals, which is drug-induced usually, and a good percentage of drugs causes this type of injury, like this patient here, which was on acyclovir. I have also a patient with amphotericin, which was on amphotericin, and these type, and they will polarize very nicely again. And as you can see here, this is extensive crystals. Also, interestingly, what would cause this type of injury are some of the cosmetic products, hair products, which females use, and they can also cause this type of crystalline tubular injury. But we have to consider oxalosis, of course. If the patient's age allows for this, to consider primary hyperoxalosis, and this is how primary hyperoxalosis looks like. This is classic oxalate nephropathy with the rhomboid refractive crystals, as you can see here, under polarized light. They look very nice under polarization, as you can see, with all types of colors. In oxalate nephropathy, usually gets surrounding tubulointerstitial inflammation, much more prominent than those with just an acute tubular injury with crystals, and depends on the stage, of course, of the oxalosis, whether you're going to have associated fibrosis or not. So yes, acute tubular injury with oxalosis, if in a young patient, we have to consider primary hyperoxaluria, but you also need to know that acute tubular injury, especially the toxic ones, whether drugs, whether any other type of toxins, can also cause crystals within the tubules. And this type of tubular injury takes time usually to resolve, because the presence of the oxalate crystals just won't resolve spontaneously. So they might take a longer time to recover than your regular tubular injury without oxalosis or without crystals. This is why it's an important point to consider within the pathology.
There are some case reports in the literature about acute oxalate nephropathy for those who consume huge amount of tea or iced tea, and for those who have bariatric surgery and those who have Crohn's disease. So
this is the secondary, yes. This is the secondary form of hyperoxalosis, and of course, this is bariatric surgery specific, because bariatric surgery are going, case reports for those who consume a lot of iced tea, or as I'm going to show you, for in Africa, for example, for those who consume cranberry juice, because they have cranberry juice as their, they drink it as much as they drink water, and this also causes oxalosis. So you have other causes, but what we're seeing more common are the ones with bariatric surgeries, because bariatric surgeries are expanding. And first it was limited to those who do gastric bypass, but now we also see it with sleeve patients.
Okay.
And yes, so, and these patients are not able to hydrate well, and if they have a tendency for any form of dehydration, they do present with acute oxalate nephropathy. Also, this is an important point to consider, since we brought up other causes of secondary hyperoxalosis. in what we are in now, in COVID-19, the excess abuse of vitamin C. And we are getting into the summer, والجو بيتحرر جدا, and then this can also precipitate that we start to see patients with acute tubular injury with oxalosis, because people are also abusing vitamin C. So
also vitamin B12
and vitamin B12.
abusing vitamin B12 يعني العيانين اللي بياخدوا كل يوم والدكاتره بتدوهم فيتامين بي 12 تراي بي انجكشن وفيتامين بي 12 كل يوم وكلام زي كده. الكلام ده توكسيك، ممكن يعمل اكوت كدني انجري ان ذا فورم اوف اوكزالات، فنخلي بالنا من الكلام ده.
اهم حاجه احنا شعب ما عندناش culture بتاع hydrating well. We don't have the culture of drinking water, and this is why we are more prone to see these types of injury rather than other populations, although we live in a hot climate. So our patients have more tendency to see this. So yes, don't ignore it. If the patient does not have primary hyperoxaluria, that does not mean that he does not have any other cause for his acute tubular injury with oxalates. And let me tell you that, as I said, this type of injury can be chronic and can cause residual injury. So don't take it lightly. You need really to investigate properly your patient. Now, this is a 36-year-old male who presented with a serum creatinine 6, recently discovered, all of a sudden. His protein creatinine ratio was 900. Again, negative history for everything. No hypertension, no diabetes, no drug abuse, no immunology negative, virology negative, everything is negative. This is all what we have. He presented with a serum creatinine of 6. Let me just show you his biopsy. Now, this was part of his biopsy, and he had an interstitial nephritis with eosinophils. Interesting. But look at his tubules. I have to allude again, this is a very rare type of crystalline nephropathies known as 2,8-dihydroxyadenine nephropathy. This is a hereditary form of nephropathy. It runs in families. It's post-transplant. We have a few cases, a pre-transplant. This is one of these patients, and this patient was really amazing, the extent of crystals. And the crystals here is different. This is a light microscopy diagnosis, of course, as all tubulointerstitial diseases. But you can see that the crystals here are brown, and they tend to be small. Look at them. Look at these. And they have this, what they call sun ray arrangement. They look like sun. Now, the important point of realizing this type of nephropathy is that these patients are actually very well controlled on allopurinol. So this is extremely important. So the two important points about this rare disease is that it's familial. These patients are well controlled on allopurinol, and they really need to be diagnosed because this have 100% recurrence post-transplant, and they recur much earlier than oxalate nephropathy. Oxalate nephropathy takes around 2 weeks post-transplant. نعم.
في allow me، انا بس عاوز اسالك سؤال، هل احنا بنحتاج سبيشال ستين او سبيشال مايكروسكوبي عشان نبقى كونفيدنت في الدياجنوزس؟
نو.
الحاجه الثانيه، احنا كان عندنا كيس بوست ترانسبلانت وفعلا احنا سسبكتنج القصه ديت واستجابت للالوبرينول، واحنا ما عرفناش ننشرها علشان ما قسناش الانزيم ليفل في الار بي سيز عشان تبقى بابليشبل. هل مجرد لايت مايكروسكوب؟
يس. This is pathognomonic.
ده انا كنت متخيل، لان هو في الحالات اللي منشوره قبل كده كانوا بيفحصوها بسبيشال ميكروسكوب وسبيشال ستين وحاجات زي كده، وعشان تكونفيرم الدياجنوز بيقيس الانزيم في الار بي سيز.
هو اكشولي معظم الناس كانت بتانلايز الستون.
ايوه.
يعني some of these patients are stone formers. فكانوا chemical analysis of the stone بيطلع ان هي adenine. لكن this is pathognomonic.
Okay, ماشي.
This is a very classic, so you can publish it. Yes.
Okay.
Now, cholesterol crystals. I know you all know about cholesterol emboli, and that cholesterol emboli are mainly in blood vessels because they are emboli, but you can see actually cholesterol crystals within the tubulointerstitium. And they are much more common than the ones we see in blood vessels. And these are important findings because it tells you that your patient is prone to have cholesterol emboli. And look, this is a cholesterol emboli in the tubules, as you can see here. And look, this is the cholesterol emboli in the blood vessel. This patient, of course, had fatal atheroemboli, but you can have atheroemboli within the tubulointerstitium. You can have this cholesterol emboli, and this is an important point to be reported, because then you know that your patient is prone to cholesterol emboli. Uric acid nephropathy or gout. Now, myself, as Wesam Ismail, believes that there is absolutely nothing called gout nephropathy. This disease doesn't exist. And this is only an incidental finding within the biopsy. They're very nice morphologically. You can see this with giant cells. They usually look bluish. They have these granulomas, amorphous structure, and they are in the medulla. They're also always seen in the corticomedullary junction. This is an incidental finding. This has absolutely no relation to what's wrong with the patient or why the biopsy was taken. So not an accepted diagnosis.
And I want to just confirm your concept. Yes, the majority of authors nowadays decline this diagnosis. Nothing uric acid nephropathy or gouty nephropathy. I think
this doesn't exist.
Yeah.
Yes.
Many of authors agree with your view.
Great. So also just don't ما تخلوهاش شماعة نحط عليها what is wrong with the patient. This is not what is wrong with the patient. This is a nice incidental finding just to see for pathologists, of course, not for the patient. And of course, we've discussed this before, that within the crystals you can see is light chain proximal tubulopathy. I'm not going to cover it again. Let's move to something else. Now, this is a 56-year-old male who presented with a serum creatinine of 5.6 and no significant history. He has no proteinuria or hematuria. He is hypertensive and diabetic and controlled on medication. And his ultrasonography revealed a right iliac mass, which was query cancer colon, and his kidney size were enlarged. So this patient had a clue for his diagnosis, which is enlarged kidney size. Usually a clue in pediatric patients, but it's always an important clue. So differential diagnosis of enlarged kidney size is amyloidosis, of course, number one. But number two is lymphomatous infiltrate in the kidney. This patient had a lymphoma, and what the mass they have seen in the GIT was probably the lymphoma. Now, this is a lymphomatous infiltrate, and well, I cannot tell you, I'm not going to get into details how we know that this is malignant infiltrate and rather not a benign infiltrate. This is what pathologists do. It's not always that easy, but trained pathologists can suspect that this is a malignant infiltrate and get diffuse infiltrate within the kidney. And as you can see here, extensive lymphomatous infiltrate. And of course, we do the phenotyping or the characterization of the cellular infiltrate, and this patient had CD20, so B cells, so this patient had a B cell lymphoma. Not a common finding, but you can see it every now and then, and needs to be also considered with these patients presenting with an AKI, elderly patients. Which gets us to another entity, which is TIN with immune complex deposits. So all what we've discussed were types of tubulointerstitial diseases, but where we can only diagnose them by light microscopy diagnosis. However, we have a spectrum of TIN with immune complex deposits, where you can actually see deposits with the immuno. Now, this type of tubulointerstitial nephritis can be without glomerulopathy or with glomerulopathy. If we have a glomerulopathy, it occurs in idiopathic hypocomplementic interstitial nephritis, an IgG4 with TIN. In polyoma virus nephropathy, you can also see immune globulins. Sjogren, lupus, rare. If it comes without glomerulopathy, it's reported, but it's very rare. Or with glomerulopathy. Then with glomerulopathy, lupus comes first, because this is the commonest type of glomerular disease, which is going to give you immune complex deposits within the tubular basement membranes. Sjogren, of course, than any other disease. Cryoglobulinemia, non-steroidal abuse can also give you some non-specific immune complex deposits or could be idiopathic. And of course, we have the anti-TBM or like anti-GBM. We have autoimmune anti-tubular basement membrane disease, which is extremely rare. This is a 36-year-old male who presented with a serum creat of 3 and no significant history. Again, everything is negative, not to bore you. No proteinuria, no hematuria, everything is negative. What's interesting about this patient was that this patient actually presented with unexplained rise in liver enzymes. And he was following up with a hepatologist. And his unexplained rise in the liver enzymes, everything was negative. All his profiles were negative, autoimmune, virology, everything. However, upon his routine checkup, the hepatologist found that his serum creatinine was increasing and it had reached up to 2.5 by the time of the biopsy. So the hepatologist decided to have a renal biopsy on the hope that this patient could be diagnosed. So this is a patient, young adult, who presented with acute renal impairment and unexplained rise in liver enzymes. The history has a clue for diagnosis, but let me show you his biopsy.
Bilirubin was normal?
Yes, everything was normal. And this is why they also did not take a liver biopsy. And it's good because he was not going to be diagnosed with the liver biopsy. Now look at his biopsy. This is a trichrome stain. And I remember this biopsy very well because I had a fellow training at that time. And he told me, look, this is an end-stage kidney. This patient has extensive fibrosis. And after the biopsy, I told him, which doesn't make sense. Yes, the patient creatinine was actually only around 2. So yes, this very specific pattern of fibrosis. This is not your normal fibrosis. This is storiform appearance of fibrosis. And you can see here that actually the inflammatory cells surrounding the interstitial fibrosis. This is pathognomonic, actually. This is a very highly characteristic feature of IgG4-related disease, this pattern of fibrosis. And IgG4 systemic disease affects early on the bile ducts. This is why this patient had unexplained rise in liver enzymes. And we've done IgG4 for him. As you can see, this is the ratio of the IgG. This is the same field to the ratio of IgG4. And when I informed the hepatologist that this is probably IgG4-related systemic disease, she went on and I've done the rest of the investigations and the patient was really IgG4-related disease. Now, IgG4-associated systemic disease manifests as autoimmune pancreatitis, Sjogren's syndrome, and don't forget this one, sclerosing cholangitis, inflammatory bowel disease, inflammatory pseudotumors, lung, breast, liver, and I had a patient presented with inflammatory pseudotumor in the peritoneum and tubulointerstitial nephritis, among several forms of this systemic related disease. These are not common diseases, but they are not rare. And we also need to consider them, especially because not always the patients are going to come with this classic appearance of interstitial fibrosis. So you need to have them within the differential diagnosis. And of course, as you all know, that we have some cases of IgG4 membranous, also nephropathy related within the spectrum of IgG4-related systemic disease. I'm not going to get into the diagnostic criteria. You can dig it out of the literature or any textbook. But the important one is that you have a plasma cell-rich tubulointerstitial nephritis. And this is, again, the importance of characterizing the inflammatory infiltrate within the tubulointerstitial nephritis, because when we get a plasma cell-rich tubulointerstitial nephritis, the differential diagnosis can be limited, and you have to consider IgG4-related systemic disease as the first diagnosis, and the second diagnosis is Sjogren's syndrome, which is more or less the same entity, but some patients can present with Sjogren's syndrome first. Again, an underdiagnosed disease. Patients with Sjogren's syndrome presents only like this, and we have a case for a young female who presented only with this mild tubulointerstitial nephritis, and potassium abnormalities, which were only noted after the biopsy with a mild renal impairment. So Sjogren mainly gives you this active chronic interstitial nephritis, and when it is plasma dominant, you have to really exclude Sjogren first, and within the same spectrum, of course, IgG4-related systemic disease. However, Sjogren can also present with a dominant CD3 infiltrate if it's within the full-blown autoimmune spectrum and not within the spectrum of IgG4. You get normal glomeruli and you get plasma cell-rich infiltrate, as you can see here within Sjogren. The importance of Sjogren, as you all know, that these patients can develop lymphoma. As you can, this is again Sjogren.
The importance of putting IgG4 in the diagnosis is it's a good response to steroid in the majority of the cases.
Excellent response,
Yes,
excellent response to steroids.
And
so
it is rarely needs further treatment or adjuvant treatment rather than steroid. So this is why to put in mind it is very good for the patient.
Yes, exactly, because then this is a treatable cause. And this is the importance of try as much as you can not to fall into the trap of non-specific tubulointerstitial nephritis. I'm trying to show you all the spectrum of specific tubulointerstitial diseases, including all the spectrum where you have a very good percentage of patients where you can treat and save the kidneys. This is a 60-year-old male, non-diabetic for 7 years, controlled on oral hypoglycemics, presented with acute renal failure, serum creat 6 from a baseline of 1.51 year ago, protein creat ratio 1.5 grams, bland urine, fundus early, retinopathy, we've discussed extensively, and this is ALAC2 amyloid. It has to be included because this is a tubulointerstitial disease as well, and as we've stressed before, we really need to consider it. Let's move away from inflammation a bit and show you now a different spectrum of tubulointerstitial diseases. This is a 21-year-old male who presented with serum creatinine 4.5. You might get bored of the clinical data, but this to prove the point that these patients do not have any other clinical scenario. This is how you're going to get the patients, only with an increased serum creatinine. Protein creat ratio around 1 gram, bland urine, negative immune profile, negative virology, and a 21-year-old male. Now, this is his biopsy. As you can see, his glomeruli showed this ischemic changes. Some of them actually, sometimes you get the marked up to what we call glomerulocystic changes, where you get markedly shrunken tufts with no pathology and extensive cystification of the Bowman's capsule. Sometimes they are much more than this, but I'm sorry I couldn't find a representative picture. But these patients are mainly present with a tubulointerstitial disease, and I want you to look at the tubular basement membranes. And they have, I can't say characteristic or pathognomonic, but within this clinical context, these findings can be considered characteristic and are highly suggestive. You get these markedly wrinkled tubular basement membranes, disintegrated tubular basement membranes with the deposition of this lamellar material, and with multi-layering of the tubular basement membranes, as you can see here. These tubules are even non-atrophic. They are not atrophic tubules because their lining is fine. But look at their tubular basement membranes, how thickened they are, how much wrinkled they are, and they have this material. Let me show you. Again, a nice non-atrophic tubule. How did we know it's non-atrophic? The caliber of the tubule seems fine. The epithelium is starting to be affected. But again, you can see the tubular basement membrane is markedly wrinkled, and you can see this material deposited here. And even in the non-atrophic or non-markedly affected ones, do you think this is a normal tubule? Look at how it looks. It just looks funny. And you get this integration or discontinuation of the tubular basement membranes. There is a loss of the tubular basement membrane. We don't have deposits here because this is a normal basement membrane, but this basement membrane is disintegrated and the tubules really looks funny. This is nephronophasis, or what we used to know at medullary as medullary cystic kidney disease. I know that most of you would say this is a pediatric related disease, but no. Nephronophthisis / uromodulin related ciliopathies are actually a very wide, very heterogeneous group of autosomal and recessive renal diseases that cause chronic renal failure and stage renal disease, mainly through chronic fibrosis. You don't have to have cysts. You don't have to have high uric acid. This is the commonest cause of unexplained end-stage renal disease in adolescents and young adults. So, and this is the age where you adult nephrologists see. So they come to you much more common than they come to pediatric nephrologists. We don't call them medullary cystic kidney disease anymore. We don't call them nephronophthisis anymore. We call them uromodulin related ciliopathies. If they are recessive diseases, you get to see them within an earlier age, usually before 15, 16. However, these diseases now encompass a more broader spectrum of what we call ADTKD. Now, this is autosomal dominant tubulointerstitial kidney disease. What is this? These are three major forms of autosomal dominant chronic tubulointerstitial nephritis, or ADTKD. What are these? These are related to uromodulin mutations, MUS1 mutations, and mutations in the RAN gene encoding renin. So we have three major forms of these autosomal dominant diseases. And these diseases have three cardinal features. The conditions are inherited in an autosomal dominant manner and should be considered whenever you have a parent or a child suffering from kidney disease. And of course, if we have more family members, it provides further support, but let me tell you, it's not a must. It's not a must. Sometimes your patient is the first presentation of this disease. These conditions are associated with a bland urinary sediment, ruling out glomerular disorders, and there is a variable rate of decline in kidney function. My important point is that the mean age of end-stage renal disease is around 45. In other reports, it's 65 years old. And the range is as wide from 17 years old to more than 75 years old. How are they going to present? They are going to give you the same pathology exactly like what we've discussed. We have patients who are 58 years old, patients who are 34 years old, but I have to say the commonest group of patients are the ones from 17 to 25 years. These are common diseases. Quite common in young adolescents and in young adults, quite common. Usually the ones which are uromodulin related are associated with hyperuricemia and gout in the teenage years, and these are the ones which I tell you that they present usually in earlier age, and these are the ones which were considered medullary cystic kidney disease, but not a must. Usually there are more than 17 forms of inheritance, more than 17 more phenotypes within this entity. So patients are quite heterogeneous. In the RAN associated ones, you get hyporenemia, mild hypotension, mild hyperkalemia, sometimes unexplained anemia in childhood. You can also have hyperuricemia. The MUS1 does not have any one of these symptoms. It only has slowly progressive disease. Lack of knowledge about these conditions contribute to frequent non-diagnosis. You need to know them. You need to know that they exist, because you need to know that these patients will develop end-stage renal disease. These are hereditary disease. You cannot transplant them from their families. You need to check their siblings. You need to check their children and know, even if we cannot treat them, but you can still manage these patients and you can easily obtain a diagnosis and improve patient care. If this is all what we find, and with the biopsy, then you can have it. Biopsy is not encouraged in these diseases, to be very honest, because when you have genetic testing, but if you don't have genetic testing, then your only way out is the biopsy. If the biopsy is suggestive, consider these diseases and know that we have this entity of hereditary tubulointerstitial kidney diseases, which can present at any age. If it's recessive, you're going to see it more in children. If it's autosomal dominant, then you tend to move into the adult era up to even more than 75 years old. The second uncommon entity, again, is this is a special entity. It's called Balkan endemic nephropathy. And Balkan endemic nephropathy is related to countries in the Balkan area, like Croatia, Bosnia, Serbia, Bulgaria, Romania, and so on. Now, why am I presenting this? Because I'm going to show you that this is actually also one of the, and there is, it actually overlaps with another entity known, the toxic entity known as the acetylnucleic acid nephropathy, also common in this area. And these patients have genetic predisposition and a role which is played by coronavirus, because they do have some endemic variety there, heavy metals, ochratoxin, and mycotoxins. This is chronic progressive renal disease of unknown etiology, but it's frequently accompanied by urinary upper tract malignancy. And these are the patients which are actually exposed to the ochratoxins and the mycotoxins. But the most recent...
Ochratoxin is the most common cause of Balkan endemic nephropathy. And although it is in Balkan, but in Egypt we can have it from herbal remedies. الأعشاب الصينية بتبقى مغشوشة بالأوكراتوكسين.
I'll mention herbal nephropathies right now.
ممكن نعمل chronic tubulointerstitial nephritis وتيومرز في اليورين تراكت ولازم يتحط في الحسبان. عشان كده أنا بقول دايما ابعدوا عن الهربس.
وكان برضو من can be considered one of the etiologies of cardiomegalytic tubulointerstitial nephritis.
Okay.
As well. So yes, طبعا لازم تحط في الحسبان. Recently بقى من كام سنة كده 6 to 7 years ago we had an entity which was called Mesoamerican nephropathy. However, this entity had differed in the medical literature during the last I think 10 years. It's safe to say that it's been 10 years. Chronic interstitial nephritis in agricultural communities, CNAC, chronic kidney disease of unknown origin, uncertain origin, unknown etiology, agrochemical nephropathy, and it has also been referred to its origin. So we have Central American nephropathy, Mesoamerican, Salvadoran, architectural nephropathy, chronic tubulointerstitial kidney disease of Central America, and so on, and Sri Lankan architectural nephropathy, and so on. However, we did see cases among non-agricultural workers, including women and children who live in the same environment. And this type of nephropathy is defined as a form of non-specific chronic kidney disease that affects mainly young men, occasionally women. Its etiology is not linked to any systemic disease, so it's a diagnosis of exclusion. Patients have to live and work in poor agricultural communities located in endemic areas with a hot tropical climate and are exposed to toxic chemicals through ingestion or inhalation or even skin exposure. The disease is characterized by low or absent proteinuria, small kidney size with irregular contours. Usually patients present with CKD stage 3 to 4, and you have non-specific tubulointerstitial lesions and glomerulosclerosis. Now, this is what we knew up to 2016, and I have to say that the work of Mark Dubrow, who actually refused from day one the concept which was proposed by Rick Johnson in their earlier studies in Sri Lanka and in Sri Lankan nephropathy, that this was a heat-related nephropathy and that it was related to dehydration. Mark Dubrow was not convinced by this, and their latest, very recent paper, and I know this was an excellent presentation in the last Egyptian Society meeting, and where they have proved that they can find specific features for what they called CNAC, and that this is basically a toxic induced proximal tubular nephropathy, and it's not related to dehydration. It's a lysosomal disorder, and they have shown actually the toxins within the proximal tubular epithelial cells, and that they have a specific appearance within the electron microscopy. So this type of diagnosis, according to them, requires silver stain and electron microscopy and a clinical context, a classic clinical context, that these patients have to be within agricultural community. He does not have to be a farmer, but lives within this agricultural community. The latest, most recent entity in interstitial nephritis is immune checkpoint inhibitors. Now, immune checkpoint inhibitors are an evolving drugs mainly used for treatment of malignancy, and we normally have immune checkpoints. This is a normal part of the immune system, and the role is to prevent an immune response from being so strong that it destroys our healthy cells in the body. These immune therapy drugs are targeted to actually induce this immune response, so in order to be able to kill the malignant cells. The commonest drugs known are actually CTLA-4 and PD-L1. And PD-L1 is an available drug, FDA approved available drug in the market for the treatment and management of patients with malignancy. It's not yet very common in Egypt because of its cost. It's still very expensive. However, already patients are taking it. How do we select the patients? Pathologists perform the PD-L1 staining in the tumor biopsies, and if it's positive, then patient receive this. We already have a study, for example, in Beni Suef on PD-L1 biopsies in urinary bladder carcinomas, and we have a good percentage of these patients who can benefit actually from this type of treatment. This is basically what this is actually what happens when you give anti-PD-L1. You release the T cell from its inhibition, and then it can attack the tumor cell and causes a death. These are less cytotoxic drugs than the conventional chemotherapy. However, of course, they have a lot of side effects. The important side effect is that these drugs are nephrotoxic and causes mainly interstitial nephritis. So they are a good, you have to consider it if you see a patient like this, and this interstitial nephritis is more common with PD-L1 treatment than the CTLA-4. Also, as transplant patients are more at risk for malignant tumors, and so when these trials or studies in transplant population, these drugs had an increased risk for acute allograft rejection and failure expected, of course, because this is a drug which cancels the off signal of the immune system, so you have an unleashed immune system to attack your graft.
ان شاء الله يوم الجمعه اللي جايه انا هعرض من ضمن الهوت ايشوز في الايمون سبريشن السيستماتيك ريفيو منشور في وزن دايز على كل التوتال كيسز اوف ترانسبلانت تريتد وذ تشيك بوينت انهبيتورز، ويعني وفي جايد لاينز هنقولها ان شاء الله يوم الجمعه باذن الله.
ان شاء الله. انا بس as I said, okay, my last entity is one of the most interesting ones, but a very important ones. You don't consider them within your differential diagnosis. Dr. Hussein just alluded to them, is herbal nephropathies. We are in a country where our patients actually treat themselves with herbs, use herbs as diet regimens, anti-weight loss regimen, everything. عيانينا بيروحوا للعطارين أكتر ما بيروحوا للدكاترة. They take different recipes. So consider always this entity when you're considering tubulointerstitial disease, that toxic tubulointerstitial nephritis or tubulointerstitial injury does not always have to have drugs. And a negative drug history, then look for herbs and you will find it. Believe me, you will find it. This is a popular use of complementary and alternative herbal medicine. The toxicity could be from a herb, which we don't know that it's toxic. However, it's more common with incorrect identification, substitution of an innocuous herb with a toxic one. Because if you go to anyone with no experience in herbs, أي عطار, any herbal shop, which does not even know how to recognize the proper herbs, then he can replace the innocent herb with the toxic ones. Preparations, usually herbal preparations, have other substances which are non-herbal, and it is these substances which are non-toxic, like as Dr. Hussein just mentioned, the Chinese herbs. Believe it or not, the Chinese herbs themselves are not toxic. The problem is with the type of Chinese herbs we import. You get not original Chinese herbs, and the problem is with the substances which are mixed with these herbs. When I was in Hong Kong, and I was also giving a presentation about tropical nephropathy, and we went to one of these herbal shops, and they're very common in Hong Kong. And actually, yes, these herbs are non-toxic, according to the Chinese. The problem is in the type of herbs you obtain out of China. And of course, the most important thing.
اسمحي لي يا دكتور وسام، بس دكتور خالد ابو زيد كاتب هنا adulteration. انا بحييه على المصطلح ده. adulteration يعني معناها غش الهيربال ريميديز. وما بنيجي نقرا بعض الراندومايزد كنترول ترايل بروفد سام هيربال ريميديز ان ممكن تبقى زي الاس انهبيتور وخلافه. لكن لما نيجي نقرا في الميثودولوجي، انا هجيب يقول لك القريه الفلانيه اللي بتزرعه في المزرعه الفلانيه، فالكلام ده لن يتحقق في مصر ولا في اي مكان تاني، ولا حتى في الصين في مكان اخر غير
في اي حته.
فبالتالي بناخد الكلام ده بحذر شديد جدا. يوجوال الهيربال ريميديز ادلتريتد بنون سترويدال ولاكستيف ودايوريتكس عشان يعملوا سيمتوماتيك ريليف للبيشنت اللي بيصحابه بعد كده كومبليكيشنز، طبعا غير الحاجات الاخرى. عشان ما اطولش اسيب الدكتوره وسام تكمل.
طبعا the most important point that it potentiates the nephrotoxic effect of a conventional therapy. Again, يعني لو هي اساسا conventional therapy is not being at risk of being of nephrotoxic, herbal nephropathies would potentiate the effect.
الحاجه الثانيه الوصفه زي ما حضرتك قلتي، زي ما بنيجي نقول العيان ياخد جرام مثلا اموكسيل كل كذا، هو لو خد الهيربال ريميديز بجرعه اعلى ده مشكله ثانيه. ده حتى البخاخات بتاعه الناموس والكلام ده لو اتعملت انتنسيف تعمل اكوت كدني انجري، اكوت تيبولار انجري.
طبعا دي اورجانوفوسفورس.
لو حتى اف دي ابروفد، تبقى اف دي ابروفد بدوز معينه ما نتجاوزهاش. فالقصص دي لازم تتحط في الحسبان.
انا مش عايزه اقول لك ان مش بس دول، ان الحنه
بالظبط
the extensive henna on skin or on hair causes acute tubular injury. As I said, some of the new recent cosmetic the hair straighteners and the hair treatments بيعملوا acute tubular injury and acute interstitial nephritis as an allergic reaction probably للفورمالين اللي محطوط فيهم and so on. So الموضوع أكبر كتير. So consider it, please consider it, because you would be surprised with the extent of patients, especially females, which are going to be using these herbal nephropathies. And they do underlie, we don't have a specific statistic, but they might be up to 35% of all cases of acute renal failure in Africa. This is types of actually toxic herbs away from the remedies and other substances and adulterations. Some of the herbs are actually toxic. Don't ask me to say their names because of course they are unpronounced. I cannot even pronounce them. They are very difficult names. However, you have others like ephedra seneca. This one has ephedrine, and actually it affects the renin-angiotensin system. Licorice, and of course we are a country which loves licorice, and licorice we know inhibits major renal transport processes for filtration, secretion, and absorption. High oxalate content as in star fruit, and star fruit is heavily consumed in South Africa. Cranberry juice, again, this is one of the major juices which is consumed in South and Southeast Africa, and this is a promoter of kidney stone formation.
هو consumed all over the world لان في كلام على انه بيقلل اليو تي اي.
يعني كبسولز الحقيقه هي الكرامبري كبسولز it helps actually yes with the UTI. This is true. بس هم دول بيشربوا الكرامبري جوس زي ما احنا بنشرب، مش عارفه اقول لك ايه، زي ما نشرب كركديه في رمضان مثلا. يعني whenever you go to
ما هي الدوز برضه.
Your welcome drink, yes, it's dose related of course, dose related and genetic tendency and everything.
يعني الشاي كويس، الشاي لو خدت كوبايه شاي في اليوم ما فيش مشكله، لكن لو انا هاخد 2 لتر شاي في اليوم هيجي لي اكيوت رينال فيلير من اوكزالات نفروباثي.
ده نفس الفكره بتاعت العرق سوس. شوف انت دلوقتي لما بنيجي رمضان وفي الحر وكميه العرق السوس اللي الناس بتشربه، العرق السوس بيعمل يعني هايبركاليميا عنيفه. So and you get acute allergic interstitial nephritis.
بيعمل
هايبوكاليميا عنيفه.
بيعمل هايبرتنشن وهايبوكاليميا والكالوز.
Exactly. So and of course you can get acute allergic interstitial nephritis with other herbs. So the herb itself is also important. Finally, whatever the cause of all of what we've discussed, if this is infectious, if this is non-infectious, if this is ischemic injury, if this is toxic, if these are deposits, if this is an autoimmune disease, if this is a systemic disease or a primary tubulointerstitial disease, or even idiopathic or a herbal nephropathy, whatever the cause, you have always to remember that these patients can end up with scarring and residual chronic injury, even within the context of what you consider an reversible AKI. Why? Because fibrosis develops after infiltration by mononuclear cells. So if you have an acute tubular injury and eventually you get some infiltration by mononuclear cells, these patients are going to be left with residual fibrosis. This is why we like to give some steroids. If you biopsy and we see some infiltrate, it's always good and useful to absorb, to get rid of these few lymphocytes which are present in the interstitium, because at the end of the day, this is what's going to give you the fibrosis. There is a physiological balance between ongoing matrix formation and degradation in the normal kidney. However, this balance is affected when you get infiltration by lymphocytes, because of course, they do produce a lot of chemokines and factors which promotes the fibrosis process and the deposition of extracellular matrix. This is what we call, pathologists call sclerodema. Maybe this is not a common term you see in biopsies. I don't use it a lot because I know that pathologists are not aware of it. So, and I like always to use terms which are understandable. But this is what we mean by sclerodema. Sclerodema means you have edema with early fibrosis, with early sclerosis. So these are actually the fibroblasts, and we can see them. This patient can be resolved with steroids at this stage. You will resolve the edema, the minimal interstitial inflammation, and the fibroblasts, which you can see. Otherwise, this is what you are going to get. These fibroblasts are going to transform into myofibroblasts. You're going to get collagenoses, sclerosis, and fibrosis. So this is basically the mechanism behind fibrogenesis. So within the concept of what we consider acute kidney injury and chronic kidney injury, we need to know that we are in the era of new concepts and new definitions. We've already been in the era of redefining acute kidney injury a few years back, and within this era, we have also the questions of, are they actually separate entities? Can we consider that acute kidney injury and chronic kidney disease are interconnected syndromes? Yes, we're having more and more evidence every day, and that this is a histological continuum, and that you start with an acute insult which will eventually develop chronic changes, and that this acute insult, which can be ignored or missed, or that you just tell your patient, go home without proper investigation, without insisting on a follow-up, and then this patient might well come back to you with end-stage renal disease. And we do know as a fact that chronic disease precipitates acute kidney injury. So don't be surprised of your patients who are diabetics, hypertensives, chronic glomerular diseases who come with the AKI. The fact itself of having a chronic renal disease will precipitate this patient to an AKI and make them more vulnerable. And take it the other way around, please. Please, please, please. Don't accept an AKI in a healthy young individual. Dehydration should not cause acute kidney injury in a young, full, healthy male or female patient. Just don't take it that lightly. You shouldn't. We all get dehydrated. All of us are fasting. If you are healthy and you don't have a problem, you should not develop an acute kidney injury just because of dehydration. This doesn't make sense. If you develop an AKI and you're young and healthy and have no systemic disease, you have a renal problem. You need to consider this, please. Of course, this would include toxic insults and so on, because I see this a lot. The patients, AKI, yes, they are dehydrated. No. Young, healthy individuals, even if not young, from 20 to 50 years old, and even more than this, should not simply have an AKI without an unexplained cause, just because they are dehydrated. This is not accepted. And remember also that we do have some nice experimental evidence, this is mainly whereby a focus group, that they have shown that previous tubulointerstitial disease insult may precipitate actually a later on glomerular injury. And this makes sense because we are, at the end of the day, they are all connected. So my take-home message is that the exact incidence of tubulointerstitial nephritis is unknown. We have very few biopsies in tubular interstitial nephritis and even fewer biopsies in acute kidney injury. There is a lot that we don't know about these diseases. Morphology is quite variable. It's often similar, even with variable mechanisms. We have absolutely no ideal classification, because in an ideal classification, then we should take into account clinical, etiological, pathological, and pathogenetic mechanisms. And it is very important to establish the diagnosis of tubulointerstitial nephritis through kidney biopsy. Clinical and laboratory data alone are not going to tell you the difference between TIN and other renal diseases, and are not going to tell you what is the cause of TIN. Xenophilia in urine is not going to help. Most acute tubulointerstitial nephritis can be successfully treated. Acute and chronic, actually, as we have seen. Untreated acute TIN may result in interstitial fibrosis and irreversible renal injury. And remember this, that you might be sending your patient to a route of chronic kidney disease unknowingly, because you've just decided that because his creatinine has landed, that his AKI has been resolved. And remember that kidneys are not glomeruli and are not only vessels. So AKI is not only glomerular or vasculitis. AKI is mainly tubulointerstitium, and the tubulointerstitial compartment is a very, very important part of renal diseases. Thank you.
Thank you. يعني بنشكرك شكرا جزيلا دكتور وسام، يعني عرض رائع، يعني very comprehensive atlas view for acute interstitial nephritis. وطبعا القصه فيها اشياء كثيره جدا حضرتك اشرت اليها. طبعا انا موافق ان الدهيدريشن لوحده في اليونج ايج ما بيبقاش مقنع قوي، حتى لو هو السبب الوحيد بندور على اذر ايتيولوجي. يمكن الايج الناس الكبار في السن بيبقى عندهم ريزيدوال فيبقى الدهيدريشن فيهم يعني عنصر فعال قوي جدا. لكن احنا دايما بنحط السبيكترم بتاعنا اللي هو البريرينال والرينال والبوست رينال قدامنا، والاكوت انترستيشال نفرايتس ما بقاش يعني اي حاجه ممكن تعمل انترستيشال نفرايتس، اي حاجه، روايح، اكل، شرب، ادويه، انترفين، كله ممكن يعمل اكوت انترستيشال نفرايتس بشكل او باخر. فعشان كده الواحد لازم يبقى حريص جدا في الدراج بريسكريبشنز وفي كل حاجه. دكتور سعيد اتفضل. دكتور سعيد خميس.
شكرا دكتور حسين. سامعني كده؟
سامعك كويس، اتفضل.
طبعا انا متشكر للدكتوره وسام، وعرض اكثر من رائع للذي بصراحه. ولو هتكلم نقول نيفروباثولوجيكال بوينت اوف فيو، هنحط كلمه نيفرو دي بالكابيتال ليترز، لان كنت شايف النهارده نيفرولوجيست بيتكلم مش باثولوجيست بس يعني. فده مزاج اكتر للمحاضره بصراحه يعني.
في ليك تعليق يا دكتور سعيد؟ اتفضل.
اعلق اذا سمحت لي حضرتك.
اتفضل.
في تعليق وفي سؤال، بس التعليق بسرعه بالنسبه للاوتوزومال دوميننت تيوبولوانترستيشال كيدني ديزيز. اكشوالي فعلا انا قابلت كلاسترنج.
انا كنت متاكد ان انت هتجيب سيره الديزيز ده.
لان انا قابلت فاميلي كامله بالقصه ديت، كنت ساعتها في السعوديه، وكان الدكتور سعيد الغامدي طبعا استاذنا كان موجود، واتناقشت انا وهو في القصه دي. وحتى الارتكل ده كان في اللي وريته الدكتوره وسام في كان ريفيو ارتكل سنه 2017 ومنشور في الادفانس اوف سي كي دي جورنال. واتناقشت قلت له وارد يكون العيله دي كده، لانها نفس السيناريو فعلا. هل هي ميو سي 1 ولا ام او دي ولا رين جين او كده؟ قال لي انا عندي كذا فاميلي من سيتي معينه نفس القصه دي وانكسبليند. وهي القصه اما وصل الاند ستيج مش هنعمل حاجه، بس هي الفكره عشان الفاميلي بالنسبه للدونيشن وبالنسبه للترانسبلانتيشن. فكان بلاننج ان انا وهو هنعمل ساعتها هنعمل جينيتك ستاديز وكده. بس انا انفورشنتلي اي كيم باك تو ايجيبت ساعتها. فاني واي يعني ان نحط في دماغنا زي ما الدكتوره وسام قالت ان ده احد الاسباب وسبب برضه مهم. وي شود نوت نجلكت في الانكسبليند كلاسترنج اوف سي دي في العيانين اللي هم في السن اللي قالت عليه الدكتوره وسام في 20 years old وكده. الجزء الثاني بقى في السؤال اللي عاوز اساله الدكتوره وسام بالنسبه للنون ستيرويدال، وده المشكله البعبع الرئيسي بتاعنا في الدرج او ياتروجينيك انفورماتيف زي ما تفتكر دكتور حسين.
اتفضل.
الجلوميرولوباسي اللي بيحصل معاه دكتوره وسام، حضرتك طبعا وارد يحصل مينيمال تشينج او وارد يحصل ممبرينس مع النون ستيرويدال بلس طبعا تيبوانترستينوفرايتس. من خبره حضرتك بتشوفي فعلا از ات كومن ان تلاقي جلوميرولار ديس اوردر او جلوميرولوباسي مع العيانين دول؟ شكرا جزيلا.
Yes, I can't say common أو إن يعني I can't say إن الجلوميرولوباثي ما فيش عندي حاجة تخليني أحلف إن الجلوميرولوباثي اللي موجودة related to non-steroidal, but the spectrum we see with patients who come with only this type of history إن هو ده الحاجة الوحيدة significant. Yes, we see minimal change and we see membranous. We see both equally and we see acute tubular injury. Actually بقى more common عن الانترستيشن nephritis and full blown interstitial nephritis.
تمام.
يعني we see a tubular injury more common عن الانترستيشن nephritis, especially when it comes with the glomerulopathy. يعني مع الممبرانس ومينيمال تشينج بنشوف tubular injury اكتر كتير بنشوف tubular interstitial nephritis. Usually tubular interstitial nephritis بسين glomerulopathy, بس طبعا ده يعني personal observation يعني only with يعني related to our experience.
هو كلو في الهيست جود هيستوري والباثولوجي طبعا. ولو العيان جايب نفروتيك سندروم اكمبانينج كدني كرياتين عالي بحط البوسيبيليتي اوف مينيمال تشينج.
في الممبرانس الموضوع بيبقى سهل تو اكسكلود دلوقتي. احنا طبعا بنعمل فوسفولايبيز وبندور على وثرومبوسبوندين وبنشوف اذا كان الممبرانس ده فعلا يعني برايمري ولا سكندري ولا انسيدنتال فايندنج. في مينيمال تشينج I cannot say, بس طبعا it's a very good يعني if you have a strong history and suggestive an exclusion and an adult patient يعني it makes sense ان المينيمال تشينج الموجود is related to non steroids.
دكتور طارق طنطاوي.
والله يا دكتور وسام انا سعيد جدا من البانوراميك ليكتشر النهارده. وفعلا احنا في اليانج ايج وات ايفر هو ميل او فيميل، احنا الفيميل فعلا زي ما حضرتك تطرقتي النسايدز فيري كومن مع البينز او مع المود بتاع الجيرلز في السن الصغير. لكن احنا عندنا بالنسبه للميل في مشكله كبيره جدا، الهرمز والسبلمنت اللي بياخدوها في الجيم. يعني بنشوف حالات فريكت بتيجي باكوت انترستيشال نفرايتس، ولو الدكتور مش منتبه لكده فعلا البيشنت ده ممكن بيخش بروسيد في ديتوريشن لكدن فانكشن في كرونيك كدني ديزيز تو داياليسيس. والموضوع بيكون ايرلي ان انا لو هاخد هيستوري كويس او اقول الدراجز. على فكره كمان القصه عندنا مش سبلمنت بس، احنا كمان اللي هم الادكتس والدراج ابيوز موجود عندنا في الشباب الصغير الميل. ولو ما كانش النفرولوجي قاعد وفاهم هذا الكلام ده كويس بيمس حاجه مهمه جدا جدا في المانجمنت. انا بشكرك حضرة البانوراميك اللي كلير، وفعلا احنا بنريسبكت البارت بتاع التيوبولو انترستيشال كومبوننت بتاع الكدني، وده مهم قوي وميزد على فكره في البراكس بتاعنا. شكرا يا دكتور وسام.
هو كومنت بس على الدراجز. again this is a personal own personal experience يعني the common drugs which are abused الحشيش والترامادول we haven't seen
هيروين
والهيروين طبعا، بس احنا شفناش منهم قوي tubular interstitial nephritis actually. I've seen more glomerular diseases which could not be related يعني ما اعرفش اذا كان related ولا لا، especially ترامادول. الحشيش مش بنشوفش منه اي حاجه خالص، هو مش نفروتوكسيك يعني it's usually an incidental finding. الهيروين most of the cases I have seen heroin had HCV associated, so the main problem with HCV. فيعني برضو مش عايزه overload ان احنا نقول ان if the patient is on hash or is on tramadol and he's presenting with AKI don't consider it يعني او لا you need a biopsy. I've seen a lot of FLG.
والسبلمنت اللي هي في الجيم فكره
انا الحقيقه يعني انا عارفه طبعا يعني عبد الجواد وسامح اتكلموا عليها extensively with different opinions, but what we've seen of our own experience, the few cases we only had one case with end-stage renal disease, بس ده كان بطل مصر يعني. مش لازم في ايه بقى عشان مش عايزين، لكن so I was
لا في حالات بتريكفر سبونتينيوسلي
في حالات بتريكفر
مع
طبعا this would follow
مع
under
مع
of course. بس يعني the main concern was more that whether these patients have this protein overload and hyperfiltrating injury with the FSGS and so on. But otherwise, yes, of course, they can cause like any other drugs, AKI. My final message أنا يعني target زي ما أنا ابتديت في الأول وقلت إن this is going to be an overview. I'll try to make it as much as possible comprehensive. إذا أنا بس أحاول أخرج الناس وكل زمايلنا الصغيرين من النارو بوكس of ان tubulointerstitial nephritis and acute tubular injury are non-steroidal induced، وان نعرف ان this is a very important aspect. It covers a lot of diseases and you have to consider it, and actually they are much more common than glomerular diseases, and so the percentage of our patients are more. فهو ده يعني كان main target of this يعني overview of
دكتور طارق هتستغرب ان ما اقول لك ان حتى مشروب الطاقه اللي الشباب ساعات بياخدوه
بيعمل
لو زودوا فيها ممكن يعمل اكيوت رينال فيلير، وشفنا حاله كريسنتيك نفرايتس ريليت لمشروب الطاقه. دكتور طارق دمرداش، دكتور طارق دمرداش اتفضل.
اهلا بيك.
اهلا بحضرتك.
شكرا، الف شكر دكتوره وسام، الف شكر دكتور حسين، بصراحه محاضره ممتازه جدا، وان شاء الله نلتقي على خير ان شاء الله.
ان شاء الله.
احنا اتشرفنا بوجود سعادتك يا فندم. دكتور ابراهيم
الله يخليك، الف شكر
يا باشا.
وهستاذنكم لان جالي كول دلوقتي.
اتفضل اتفضل اتفضل، ربنا معاك. اتفضل دكتور ابراهيم، رافع ايده من زمان. اتفضل.
شكرا حضرتك يا فندم. والله انا عندي بس يعني 3 اسئله. اول سؤال، معلش يا فندم، اول سؤال
دكتور ابراهيم
طب معلش يا فندم حضرتك جاوب على اللي تقدروا عليه. اول سؤال بالنسبه لحالات اللوبس، قالوا والله ان ريرلي ممكن يعمل انفولفمنت للانترستيشن بس ويزود جلوميرولار افكشن، يعني يعمل كرونيك فورم الاميونوفلوريسنس بتاعه بيكون برضه معاه امين كومبلكس، وبالتالي ممكن اد فيرذر تريتمنت اذر ذان سترويد مثلا زي الاندوكسان والحاجات دي كده. ده اول سؤال. ثاني سؤال، والله
انا بخلي السؤال ده
انا بس نجاوب سؤال. Yes, it's been reported that very rarely ممكن lupus can come with only tubulointerstitial nephritis. So if I know that this patient is lupus وعندي tubulointerstitial nephritis with immune complex deposits, I'm not considering sampling issues, then yes, you can consider treatment, but definitely مش cyclophosphamide, because you know cyclophosphamide, you need to give it in aggressive forms with crescents and with necrosis. So if you want to consider this quite rare entity, and I'm stressing on it علشان بس ما حدش يستسهلها، لأن lupus patients can have tubulointerstitial nephritis for other causes. أولهم إنهم ياخدوا herbs أو إنهم ياخدوا non-steroidals for the pains of arthritis they have and the arthralgias. فيعني الأول consider other things.
واعتقد يا دكتور وسام ده اللي خلى الرينال باثولوجي سوسايتي والاي اس ان في الكلاسيفيكيشن بتاعهم لسه فاليد لغايه النهارده.
عمرها
يجنور، يعني احنا دايما بنكريتسايز ونقول ان هو جلوميرولوسنتريك، لان على ما يبدو ان ده الصح يعني، وهو ده اللي بيكاركترايز الديزيز.
ايوه بالظبط. احنا بنكريتسايز ان جلوميرولوسنتريك عشان we need to consider tubulointerstitial for prognosis.
يس
وبرضه الاهميه بتاعت الtubulointerstitial inflammation with few glomeruli، او لو انا مش شايفه activity ان it makes me consider missed activity. لكن انا مش هشخص lupus، مش هشخص active lupus وادي aggressive treatment على tubulointerstitial infiltrate. No. How would you know and this is not caused by anything else in a lupus patient؟
موافقين تمام. ابراهيم السيد.
السؤال الثاني.
السؤال الثاني حضرتك، لو انا عندي مثلا عيان جاي لي فيه سكيلتال فيشرز وفي سي كي دي وفي هايبروليسيميا،
جالك بس
اول حاجه ايه؟ اول حاجه ايه بس معلش؟
او عيان مثلا انا شخصت موديلر سيستيك كدني، العيان جاي لي كلينيكال اساسا وهايبروليسيميا وسي كي دي الكرات بتاعه 3 ومفيش انيميا، وجيت عملت له مثلا السي تي او عملت له ام ار اي طلع لي والله في مالتيبل سيست في المظله او عند الكورتيكو موديلري جانكشن. في الحاله ديت انا شخصته كلينيكلي ان هو موديلر سيستيك كدني ديزيز، لان ما عنديش اي حاجه نظر ديفرنشال دايجنوزز. ستيل برضه محتاج ان انا اعمل له بيوبسي عشان كونفيرم الدايجنوزز لو انا كمان ما عنديش جينيتك تيست. يعني
لا طبعا
biopsy is not confirmatory at all. No. Biopsy is not confirmatory at all. Biopsy is helpful in these patients with no cysts or cysts which can be attributed to as from chronic
تمام.
from CKD. لكن otherwise no.
تمام.
اخر سؤال.
طب السؤال الاخر يا فندم،
الصوت
احنا
رايح.
عندنا والله حالتين، لورنس مونبيدل، واحد اند ستيج. يا فندم عندنا حالتين، لورنس مونبيدل باردت سندروم، واحد ستيج 3 وواحد ستيج 5 بيغسل اوريدي. الناس دول اساسا كان ممكن ايرلي مثلا، لو انا جولي ايرلي كنت ممكن ابدا معاهم مثلا فورم اوف سترويد ثيرابي، او مثلا اعمل له بايوبسي وفولو اب حاجات زي كده، ولا هو الموضوع
عشان حالتين ايه اصلا؟
شكرا يا دكتور ابراهيم. انا طبعا
ممتع.
الحالات ديت حالات انا مش عارف الحالات دي بتجي لك منين يعني، بس
لا عندنا حالتين.
ايه
ما
اصلا؟
اعتقدش ان السؤال ده يعني للدكتوره وسام، السؤال ده لينا احنا الايرلي
تمام.
المانجمنت. الايرلي دايجنوز ده شغلتنا احنا، يعني انت عندك عيان لورنس مونبيدل ده فيه كوكتيل من مانيفستيشن ملهاش اول من اخر. يعني انا يعني اشوف الريتنا واشوف مش الاوبيسيتي واشوف مش عارف ايه
حالتين، ده انت لازم تذكرهم، ده يعني بيجيبهم منين يعني؟
احنا كان عندنا حاله واحده وممكن تجيب اسوسيشن، واحد لورنس مونبيدل وجاله وخبطوا قطر، ايه المشكله يعني؟ لورنس مونبيدل وجاله انسلت عمل له كرونيك كيدني ديزيز يعني.
بالظبط.
يعني الرير كيسز ديت بتهيألي مش هتبقى مفيده للدسكشن، لكن الدكتور ابراهيم دايما عنده في جعبته حالات صعبه جدا. انا يعني شكرا دكتور ابراهيم، متشكرين. انا طبعا مش عارف اعبر عن سعادتي ازاي بمحاضره النهارده يا دكتوره وسام. يعني انا بعتذر على شويه لخبطه في التكنيكال في الاول، لان كان في
لا
لخبطه
لا انا بعتذر.
لكن الدكتور معتصم فعلا لما نجحت ان انا اعمله كوهوست عمل مجهود كبير، فانا بشكره برضو على ادارته للتين اليوم يعني. بنشكرك شكرا جزيلا دكتوره وسام، فعلا حضرتك النهارده يعني محاضره فوق الوصف يعني. بنشكر حضرتك، وان شاء الله ان نلتقي مع حضرتك بعد العيد ان شاء الله.
شكرا.
تثري مكتبه النفروباثولوجي.
ان شاء الله. لا ده حاجه جميله جدا جدا.
حاجه رائعه والله، رائعه.
دكتوره وسام عاوزه تقولي حاجه؟
لا شكرا.
سواء تروح تتصحى. طيب
كل سنه وانتم طيبين. تصلي الاول. كل سنه وانتم طيبين.
الناس كلها بتشكرك على الشاتنج برضو هنا، فيعني احنا باسمهم كلهم بنشكر حضرتك، وللجميع يعني كل سنه وانتم طيبين، ونشوفكم على خير ان شاء الله. احنا ميعادنا الاربعاء
باذن الله
مع الدكتور طارق فياض اميون سبريشن ميد ايزي، وهيبقى الجمعه ميعادنا مع البارت 2 من الاميون سبريشن سبيشال سيتويشن هوت ايشوز، وهحط في الهوت ايشوز الاميون سبريشن دراج انتر اكشن مع الانتي كوفيد ثيرابي والموديفيكيشن مع الكوفيد، لان ده طبعا هو اللي على الساحه، بالاضافه لحاجات اخرى كثيره جدا هنتناولها في هذا اليوم ان شاء الله. وهيبقى معانا الدكتور احمد حلاوه، دكتور محسن القصي من انجلترا، لان احنا هنناقش مع الكلينيكال فارماسيست بتوعنا الجينيريك والبايو سيميلر اميون سبريشن، برضه جزء من البرزنتيشن بتاع يوم الجمعه.
ان شاء الله.
بشكركم، وطبعا انا بقول للدكتوره وسام عاوزينها تبقى معانا دايما في كل حاجتنا، وان شاء الله نلتقي مع الدكتوره وسام على خير بعد العيد باذن الله. شكرا جزيلا، تصبحوا على خير. شكرا.
شكرا. طيبين. شكرا.
طيب مع السلامه.